All right, good morning, everyone, to our first session of the day. This is going to be, I think, a really good session. I'm really excited about the lineup that we have here that the program committee's put together. I'm Jeremy Warren. I'm professor of surgery, minimally invasive and hernia surgery in Greenville, South Carolina. I'll let my co-moderators introduce themselves real quickly.
I'm Brittany Mean. I do abdominal wall reconstruction at Rush University Medical Center in Chicago.
I'm Leighton Belden. I'm at Sutter Health in Roseville, California, and I do general surgery focusing on MIS hernias.
And without further ado, we'll begin with our first speaker. Professor Johan Renard is going to do a little draw and tell with us. It's going to be great.
Thank you very much. Thank you very much. I'm very happy to be here. I'm Johan from France. I'm professor of anatomy and surgery. And so I will, where can I to look there. Okay, this is a video. As you know me, I can draw anatomy on blackboard with chalks. And you ask me a global overview of the abdominal wall and then a small focus on the groin. So let's go for the first global overview. This is an anterior view. We can see the sternum and the xiphoid process. This is the last ribs cartilage. The last rib cartilage is a common cartilage for the 7th to the 10th rib. This is the 5th and the 6th ribs cartilage. Right side, we are drawing the ribs from the 5th to the 10th. I just want to say that I drew this drawing. They are new with BD, and I wanted to thank them. Left side, the same ribs cartilage and the same ribs. This is the pubis with the pubic tubercles, like this, the lateral edge of the abdomen, anterior and superior iliac spines, and the inguinal ligament. This is the linea alba, inserting behind the xiphoid process cranially until the pubis caudally, the width decrease from top to down, and this is the umbilicus. The rectus muscle insert in front of the last rib cartilage and on the xiphoid process. This is the right rectus muscle with the distal tendon on the pubis and the tendon of Henle laterally. This is a polygastric muscle with 3 to 5 intermediate tendons forming the 6-pack abdomen shape. Same anatomy left side with the left rectus muscle. Now we are drawing the superficial muscle. This is external oblique muscle with a large muscular part inserting in front of the last ribs. This is the muscular part covering cranially the rectus muscle. There is an overlap, very important. The fibers are oblique, medially and inferiorly like this. And then we can draw the large aponeurotic part of this muscle forming the inguinal ligament, forming the superficial inguinal ring. And this aponeurotic part is forming only the anterior rectus sheath from top to down. This is the aponeurotic part, and here the superficial inguinal ring. We will draw the same muscle right side, but we will cut him vertically to see what happened behind. This is the external oblique muscle, which is cut. And the aponeurotic part here, forming the inguinal ligament. And we can see behind the internal oblique muscle. This is the internal oblique muscle. It is the transition line between the muscular part and the aponeurotic part. And we can see here the aponeurotic part. This muscle will form the anterior and the posterior rectus sheath cranially. It has an anterior and a posterior lamina forming the anterior and the posterior rectus sheath cranially, but it will form only the anterior rectus sheath caudally. This is the muscular part forming the falx inguinalis for the deep inguinal ring. And again, it forms only the anterior rectus sheath caudally, like this. And finally, we can see the transversus abdominis muscle. This is the linea semilunaris, the line dividing the muscular part and the aponeurotic part with the S shape. This is the linea semilunaris. We can find here the deep inguinal ring with the lateral hernia here and the epigastric vessels like this. To understand this anatomy, we will perform 3 sections. one cranial, one in the middle, and one caudal. This is the cranial section. This is the thoracoabdominal area. We can find here the last common ribs cartilage and the seventh rib. Same anatomy left side. The rectus muscle here insert in front of the last rib cartilage, and we can see this tendon. Laterally, we can see only the muscle fibers, and then the body of these two muscles here on this suprapubic area, subxiphoid area, small muscle, a small physiologic diastasis here. External oblique muscle insert in front of the last rib, like this. And this muscle again will form only the anterior rectus sheath like this from top to down. We cannot see the internal oblique muscle here. We will see only the transversus abdominis muscle inserting behind the last rib cartilage like this and forming only the posterior rectus sheath from top to down. The insertion of the transversus abdominis muscle interdigitates with those of the diaphragm like this. This is the diaphragm on this area. Then we can draw the fatty triangle of Conze and Schumpelik, or the fatty rhomboid of Miguel, and the transversalis fascia, probably 2 layers here. I'm not sure, but I think there are 2 layers. And then the peritoneum. This is the anatomy of the cranial abdominal wall. Second section is more classical. We can find the 2 rectus with a large physiologic diastasis. The internal oblique muscle is here, always the same position, lateral from the rectus. And we can draw here the anterior and the posterior lamina, forming the anterior and the posterior rectus sheath on this location. Superficially, external oblique, and we can see here the overlap between the muscle and the rectus, very important for the anterior component separation. And this muscle is forming the anterior rectus sheath from top to down. Similarly, the transversus abdominis muscle is covering the rectus behind, like this. Again, very important for the transversus abdominis release, this anatomy. And it forms the posterior rectus sheath from top to down. Finally, transversalis fascia in white, and the peritoneum in violet. Last drawing is a caudal section. Of course, the rectus muscle are more thin, and they are in close proximity here. The internal oblique muscle here, always the same position, lateral, and the posterior lamina is passing anteriorly, and it forms only the anterior rectus sheath. External oblique now is far away. There is no overlap with the rectus, and it forms the anterior rectus sheath. And then the transversus abdominis muscle, similarly, again, there is no overlap anymore, and it forms only the anterior rectus sheath on this location. We can draw the transversalis fascia, the properitoneal fat of the radius space, with 2 layers probably of transversalis fascia and the peritoneum, and the urachus just here. This was the global introduction of the anatomy, and then you ask me to focus on the groin anatomy with a laparoscopic view. This is the posterior view. We can see the bone, the anterior and superior iliac spines. This is the posterior edge of the rectus, inserting on the pubis with the distal tendon and the tendon of Henle laterally. In the middle, linea alba, very thin on this location, followed by the fundiform ligament of the linea alba, like this, and then the umbilicus just here. We can draw the inguinal ligaments, like this, and the iliopectineal ligaments here, dividing the area into 2 parts. The lateral parts is called the lateral lacuna, muscular lacuna, with the psoas iliac muscle here, the fascia iliaca, and the femoral nerve is inside the fascia iliaca, but the lateral cutaneous nerve is outside the fascia iliaca. Medially, this is the vascular lacuna, and we can find the external iliac artery, external iliac vein, like this. Then the rectus sheath. Above the umbilicus, we can find the anterior and the posterior rectus sheath, and they are formed by the lateral muscle. The transversus abdominis muscle here, with the linea similaris here, is forming only the posterior rectus sheath from top to down, but is passing anteriorly, as we will see just after. This is the transversus abdominis muscle fibers forming the falx inguinalis, the deep inguinal ring, and I will cut this muscle on this location. Then the internal oblique muscle is here with the anterior and the posterior lamina forming the anterior and the posterior sheath. And I will cut this muscle on this location. Then more superficial external oblique muscle with the aponeurotic part forming only the anterior sheath from top to down. And this muscle is cut just here. On this drawing, we have removed the peritoneum, but we will see some transversalis fascia structures. Which one? First, the iliopubic tract of Thomson is transversalis fascia. The deep spermatic fascia is transversalis fascia. And then the interfoveolar ligament of Hesselbach is here. This ligament is forming the distal edge of the posterior rectus sheath, like this. And there is no posterior rectus sheath on this location. And this Hesselbach ligament is followed by the epigastric vessels here. Then the three arteries for the testicles, first spermatic vessels, artery and vein, funicular artery from the epigastric, and we can draw here the vas deferens. We need the bladder. This is the urachus and the bladder, receiving the two ureters, like this. Then we can draw the end of the vas, reaching the prostate with the seminal vesicles, and then we can draw the last artery, deferential artery reaching the deep inguinal ring. This is the bone with the obturator vessels, and then we can draw the corona mortis vessels. There are anastomosis vessels between the obturator vessels and the external iliac or epigastric. These vessels are here on the Cooper ligament and sometimes at risk during the dissection. Finally, we can draw here the umbilical ligaments. And again, right side, the peritoneum has been removed, but we will draw the peritoneum left side, always in violet, like this. And this peritoneum will cover all the structures. And these structures will lift the peritoneum, forming some ligaments. In the middle, with the urachus, it is the median umbilical ligament. More lateral, with the umbilical ligament, it is the medial umbilical ligament. And more lateral, with the epigastric, it is the lateral umbilical ligament. This ligament will form some fossae, and we will find three fossae: the supravesical fossa, medial umbilical fossa, and lateral umbilical fossa. On this fossa, we can recognize the three locations of primary hernias, lateral hernias, medial hernias, and femoral hernias. And we can find these hernias right side without the peritoneum, femoral, medial, lateral. We will finish this drawing with the genitofemoral nerve, with the genital branch, femoral branch. And this anatomy allows to draw two triangles, the triangle of doom with the risk on the vessels, and the triangle of pain with the risk on the nerves. I hope with these some drawings we can understand the global anatomy, and thank you very much for your attention.
Thank you so much. Next, we're going to hear from Dr. Rana Higgins from MCW. She's going to present on anatomy of the abdominal wall and IPOM anatomy.
Thank you so much to the program committee for the opportunity to present today. Dr. Renard, I cannot draw nearly as well as you, but I'm going to do my best to follow with what I can in this talk. That was beautiful. So these are my disclosures. Neither are relevant to what I'm going to be talking about today. I wanted to start initially by just talking a little bit about the history of IPOM. So an open IPOM, as it was conventionally known, was essentially midline incision. Numerous sutures were used to fixate the mesh circumferentially, and the important part of this repair was spacing those sutures about 1 centimeter apart to avoid any bowel from herniating through onto the mesh. And you would often have to create these larger subcutaneous flaps in order to do so and to create the overlap you need. This then evolved in the 90s by Dr. Carl LeBlanc, who first described it with the laparoscopic IPOM, which was essentially bridging under a defect or what's known as an underlay. Again, you could get some wider mesh overlap here, and the benefit compared to the open IPOM was that you did not need skin flaps, and you would secure the mesh with transfascial sutures or tacks. This is another picture of that view. Essentially, you can see here that the mesh is underlaying the defect with still the defect being open, but you have a greater ability to get a wider range of overlap as opposed to the historical open IPOM that had been traditionally been performed. Now, in 2004, Dr. Mark Franklin described closure of the fascial defect with sutures and then reinforcing this with mesh. And at the time, obviously, laparoscopic hernia repair really had taken off. And the way this was described was with the percutaneous use of a Carter-Thomason suture passer. And some of the advantages that were described were prevention of seroma formation and most significantly for the patient, prevention of mesh bulging. So continued reinforcement of the abdominal wall without too much bulging, but based on the fact that now you could close the defect. So this is just a pictorial description of what that looks like, using most commonly the way it's described is using the Carter-Thomason suture passer in kind of a shoelace technique, sometimes figure of 8, through percutaneous incisions through the abdominal wall and then slowly tightening them to close the defect. And then, as Dr. LeBlanc described, putting the mesh as an underlay and securing it with fascial sutures and tacks. The IPOM Plus, as the advent of robotic surgery has come around, has really been the primary way that IPOMs are performed robotically because of the ability to close the fascial defect with sutures in an easier, more ergonomic way than laparoscopically. The most important part, obviously, the IPOM is not a very technically difficult operation, but there's some very important tenets to keep in mind and thoughts and considerations when you're thinking of the anatomy of the abdominal wall to perform this operation successfully. So one of the most important things of performing an IPOM is that the abdominal wall fat must be dissected. There can often be occult small hernias that you can find, and you have to expose the peritoneum in order to close the fascial defect and to reduce all of that fat that was herniated through the abdominal wall. So you can see here that when you first go in, you see the falciform ligament there, and you see this fat on the abdominal wall, and it's not quite clear where the hernia is or how much fat is herniated in. And when you dissect that fat out, you can see there was quite a large amount of fat herniated through there. And so the key is to dissect out that fat and really make sure that you expose the peritoneum so that when you put your mesh in, that it well vascularizes into the abdominal wall. So the primary tenets are that the fat off the abdominal wall must be dissected. Again, the traditional 5 centimeters superior and inferior to the fascial defects, as was traditionally described by Dr. LeBlanc, still holds true. Often, especially for kind of upper midline hernias, you have to take down the falciform ligament. Really, the goal of the operation is to get the mesh completely opposed to the peritoneum, and you should not be suturing it into fat because ingrowth, in regard to the mesh, ingrowth into the fat is not nearly as good as when it grows into the peritoneum. So you can see that here, the mesh on the abdominal wall, essentially making sure that all of the fat is dissected either superiorly or inferiorly so that when you suture the mesh, that it's not being sutured into the fat, but into the abdominal wall. So when to do an IPOM? So when you think about the European hernia classification and the anatomy of when is an IPOM ideal, really an IPOM is most ideal for ventral hernias in the middle and in the midline of the abdominal wall. So between this M2 to M4, epigastric, umbilical, and infraumbilical. A lot of that has to do with the overlap of the mesh, the amount of fat in each space, and I'll kind of talk about the M1 and the M5 a little bit. So it's important to really always have all of these tools in your toolbox and know, is this person even a good candidate for an IPOM repair? And really between the M2 and the M4 categories is when you need to focus on that. The really two primary challenging anatomic locations in the midline for performing an IPOM are the subxiphoid hernias and the suprapubic hernias. So I'll talk a bit about that. So subxiphoid hernias are defects in the walls, abdominal walls linea alba, just below the xiphoid process, often related to cardiac procedures, chest tubes. Cardiac incisions are often a reason that you'll see them, but essentially that first 3 centimeters from the xiphoid process. My anatomic picture is not nearly as beautiful as Dr. Renard's, but this is essentially the subxiphoid hernias are an interesting confluence of not only the abdominal wall, but also the chest wall and the diaphragm. And there's numerous muscles that attach to the xiphoid process, as Dr. Renard beautifully drew for us. Anteriorly, you have the rectus abdominis, internal and external oblique. And posteriorly, you have this transverse thoracus muscle, as well as diaphragmatic muscular slips. So, and obviously behind that, all very important cardiac and pulmonary structures that you have to keep in mind. So it's a very complex conglomeration of a lot of different muscles. And obviously you have the bony landmarks there, which make it very difficult in regard to an IPOM repair. So the difficult part in performing an IPOM with a subxiphoid hernia is you cannot fixate the mesh superiorly. So really your highest point of fixation is limited by the xiphoid process and the costal margins bilaterally. So traditionally, in the way that IPOMs can be performed with this hernia is that you can have mesh overlap superiorly, but you cannot fixate it. And the thought is, well, the liver will hold it in place, and that's traditionally how it can be done if needed. And you can place the most cephalad suture about several centimeters from the edge of the mesh so that then the mesh just overlaps on the abdominal wall. But truly the ideal repair that's been described is extraperitoneal for these repairs. So you can technically do an IPOM, but always remember that your highest point of fixation has to be the xiphoid. But in order to get that 5 centimeters of overlap, you have to make sure that the superior portion of the mesh is not fixated. This was recently published in Hernia, actually, this year. This was 69 experts from 5 continents, and the consensus was that mesh should be placed in the extraperitoneal position, about 78% of them, and MIS is typically recommended either as an ETEP or a TAP. So not that it cannot be performed as an IPOM, but if possible, should definitely consider performing it in an extraperitoneal position. And then finally, the suprapubic hernias. So suprapubic hernias are the lower M5 abdominal wall midline hernias, about 3 centimeters above the pubic bone. The most important thing about a suprapubic hernia is that the bladder must be dissected inferiorly to avoid injury, and that you have to have your inferior-most point of fixation be Cooper's ligament. So this truly should not be performed in an IPOM position. There's a lot of increased risk of injury to the bladder, and so the ideal repair for a suprapubic hernia pretty much universally is an extraperitoneal repair instead of an IPOM. So in conclusion, IPOM repairs are truly best for midline M2 to M4 ventral hernias. The primary tenet of the repair, again, it's not very technically difficult, but a very important tenet to remember if you're performing these hernias is to make sure you clear the fat off the abdominal wall with at least that 5 centimeter overlap superiorly and inferiorly. Subxiphoid hernias can safely be repaired as an IPOM, but remember that that superior fixation is a limitation, and that extraperitoneal is the favored approach if possible, and that suprapubic hernias, or that those M5 hernias, should always be repaired extraperitoneal in order to avoid bladder injury, and you need to make sure you have enough inferior overlap. So thank you so much again for the opportunity to present.
We'll now have Dr. Eric Pauly from Penn State Health to discuss the anatomy of a CT, and he serves on the AHS Board of Governors.
Well, thanks for everybody for the opportunity to present. I don't need to show you any anatomy. Johan, you did everything we need. That's it. Thank you. Other questions? I do have some disclosures which should not have any relevance on what we're talking about. I did want to take a minute and put this slide back up for those of you who have not had a chance to snap the QR code. Could we go back, please? Maybe not. To snap the QR code for Neil, I want to. Neil and I were also pretty good friends, and Neil hated bachelorette parties, hated them with a passion. And I so wanted him to come to this meeting so that he and I could hate on them together, because we would frequently take pictures and send them to each other and share bachelorette party pictures. Let's talk about modern hernia surgery. And from my perspective, planning a good operation is really based heavily on cross-sectional imaging. And ultimately, what this requires you to do is to take Johan's pictures, which is how we all learn anatomy in drawings like that, but then translate it into three-dimensional cuts on a two-dimensional screen and kind of put it back together in a very different fashion than you're used to seeing it sort of slice by slice. And it really does take a complex level of visual spatial reasoning to do that. But if you want to get good at hernia surgery, you've got to get good at looking at those images ahead of time so that you can plan a robust repair. And I think the biggest problem is that when we get reports from radiologists, there's a discordance in what we say as surgeons and what radiologists say at least 70% of the time. So I want to spend a few minutes here and kind of review the normal anatomy of the abdominal wall on CT scans, and we'll talk about some relevant things, maybe a little less anatomic and more things that I look for, especially when they're out of the ordinary. And again, we'll emphasize the interplay between imaging and abdominal wall function. And for those of you who don't know, that's a Wilhelm Röntgen. In 1895, he discovered X-rays that kind of led to all of the things that we do with them nowadays. He got a Nobel Prize for that as well. So we're going to focus specifically on CT scans for the purposes of this talk. And I think the things that people know, it's widely available. We as general surgeons look at them for a lot of different reasons. They're not particularly expensive in the grand scheme of imaging studies. And what I like about them is they are not user dependent. And I'm going to explain what that means in a few minutes, as well as what I mean by pseudodynamic. Not user dependent means two things. This is probably the most important slide here. This is the anatomy of a CT scan. It's got two parts. Part one is the truth. That's the stuff that's in the images. The images are always correct. The information is always there. And then there's this part of the CT scan, which is the report, which contains some truth, but oftentimes some lies. I said there's a 70% discordance between what we see and what radiologists see. Ventral hernias are the second most common structure to be inaccurately reported, and they are the most common missed finding on imaging studies. And every time I give a radiology talk, I just go back to cases from the week before. So this is a patient that I saw in clinic last week, severe diastasis rectus with superimposed small bowel containing hernias. Well, that sounds easy to fix. Hey, wait a minute. That's not a diastasis. That's a really big ass hernia. That's the hernia that radiology is reporting, okay? So like this patient actually was mistriaged. We have some surgeons in our group who take care of big hernias and some who do small hernias. This is a small hernia with a diastasis. It went to one of the easy folks who took a look at this person and said, what are they talking about? Like, how do you misread this? But it happens pretty regularly. And the reason for this is the following. There's this concept called the invisible gorilla, and it's about inattentive blindness. This is a study where they asked radiologists to look for lung nodules. And in each CAT scan they were looking at, there were an average of 10 lung nodules, and they just kind of had to click on them. But in the final case where there were lung nodules, there was a gorilla present on the entire CT scan. And if you can't see it, it's right there. There's a gorilla there, okay? It's on every slice. All 239 slices of the scan, there's a gorilla there. And you might say, well, how often do radiologists find it? They found it about 80% of the time. But people who've never looked at a CAT scan before, the first thing they said was, why is there a gorilla there? Because they can find it a lot easier. So native observers were actually better at finding them than radiologists were. And that's part of why radiologists are perhaps a little less good at looking at hernias. They are busy looking for other things. They're busy looking for lung nodules and liver lesions and other tumors. And the last thing that they care about is a hernia. And they also don't speak the same language that we do, because in the last 10 years, we've gotten a lot better about language and how we talk about hernias. There are some other problems, and some of them have to do with how we image patients versus how patients experience their hernia. Most patients experience a hernia while standing, and we image them laying down, and it's very challenging to find hernias. There actually are upright CT scanners which were designed for orthopedic purposes, like this ankle CT scan machine, but there are full body upright CT scanners which are coming to an operating or to an imaging department near you that may help us find these hernias a bit better. But really what we do at our hospital when we really feel that it's going to be helpful for determining the hernia is to do some Valsalva imaging. And you can see some images here of patients with Valsalva CT scan that kind of emphasize how small defects like the one in the middle of that right rectus can easily be missed, except when they Valsalva and there's bowel coming through it, it's just a lot easier to find, okay? Small ventral diastasis really becomes something substantially different when the patient Valsalvas. And so when you see the patient who says, I've got this crazy big bulge in the midline, but when you look at a scan that doesn't show it, this is the reason that there's a discrepancy between those things. I'll spend just a few minutes here talking about the myofascial anatomy. Again, Johan drew it kind of in multiple versions of cross-section, but obviously we think about this in axial slices, and we think about all of the anterior abdominal wall muscles. Let's not forget the lateral and posterior abdominal wall as well, with E being the psoas, F the quadratus, and G the erector spinae. These become a lot more important when you're thinking about posterior defects, lumbar hernia defects as well. We oftentimes forget about the pyramidalis muscles. They are only present in a small percent of the population, but every once in a while they do become problematic when you're doing a posterior or inferior dissection. You start coming across muscle layers that don't make a lot of sense, and just remember that they do exist even though we don't talk about them a lot. Johan spent a good time going into the myofascial anatomy, and so again, I don't want to go into it specifically other than to say that everything that he drew on that scan, you can scroll through from top to bottom and identify defects in it. When I'm looking at a CAT scan, that's basically what I do. Your goal is to be very systematic about it. I start at the xiphoid, I work my way down to the pubis. We do midline, we do off midline, we do lateral, we do right side, we do left side. Every bit of detail that he showed in terms of where tendons are attaching, where ligaments are located, you can find them on the scans. And I think the thing we often forget to utilize is the magnification tools. Every CT scanner that you guys have has the ability to magnify these images up so you can find and see a lot of the smaller details. When I think about imaging, and we're comparing here an ultrasound, which gives you a really nice view of that fatty triangle that he described in the subxiphoid region. From my perspective, the main reason I don't like using ultrasound is not only is it very user dependent and the user is the person doing the study, but it doesn't really allow you to capture the entire confines of the abdominal wall in one sweep. It's oftentimes very challenging to even get one rectus muscle in the footprint of the ultrasound probe. And so to get a good sense of the abdominal wall to make a plan, I definitely like using CT for that purpose. Johan talked about this earlier in terms of the transversus abdominis anatomy, but as a person who does a lot of posterior component separation, I want to remind you that a lot of that anatomy, in terms of where the elements of the abdominal wall are located, can be seen on these. So behind the rectus muscle on both sides, you can see the medial border of the transversus abdominis living behind the rectus. As we work our way a little bit farther down, you can see where the muscular portion now crosses the lateral boundary of the rectus abdominis muscle. And then inferiorly, you can see that that muscle is very far lateral. It does not extend really much beyond 50% of the internal oblique muscle, just the way Johan drew it. And I also want to emphasize a point that he made, which is that the linea semilunaris, which is really that curvilinear line that is the tendinous inscriptions where the transversus ends, is different than the lateral border of the rectus abdominis muscle. And we kind of confuse those terms. We've done that in the last several years. If you look back historically, the original description of the semilunar line and the Spigelian line are very different than how we use those terms today. Johan also drew this very nicely, and again, you can see these on images, the internal oblique muscle with its anterior and posterior tendinous inscriptions. You can see it on almost any imaging study, and so if you're thinking about where am I going to divide this patient's posterior components, you can actually see that pretty nicely. This is a slide that I stole from Sean Orenstein a couple of years ago, and I'm going to keep using it because it's probably one of the best slides to explain something that I think we all do in our brains, but we do not articulate particularly well, and it will never be in a report, which is a qualitative abdominal wall assessment. And I want you to look at these two different patients and just understand that while they both have hernias that are roughly the same size, these are very different humans. If you look at the fatty tissue distribution, if you look at the rectus width and the rectus muscle shape, if you look at the lateral abdominal wall thickness, right, it's very challenging to understand how much give the lateral abdominal wall is going to have. Compliance is hard to interpret, but when you see somebody like the patient on the right-hand side here who's got a very saggy lateral sign, in your brain you have an understanding that that's going to move to the midline a lot easier. And then look at the amount of sarcopenia that these patients have, a very muscular erector spinae versus one that's almost completely fatty replaced. Same size hernia, very different humans qualitatively. We know almost nothing about how these things play into the outcomes of hernia repairs. You can also use qualitative assessments for functional complaints, and this is a patient after and before a DIEP flap was done. And her main complaint is a lower abdominal wall bulge and just a feeling of instability. And every report that she's had says there is nothing wrong with this abdominal wall. It looks fine. Except if you go back to the CAT scan that she had a few months before the procedure, you can see that there are differences. Look at the amount of bulge of the abdominal wall above the anterior superior iliac spine before versus after. Look at the thickness and the width of the rectus muscles before and after. Her complaint is entirely explained by what's on the scan, which says this is normal, even though it's clearly not. I'm going to skip over the semilunar line anatomy here in the interest of time, as was outlined by Johan earlier, and just say a few things about vascular anatomy. We don't normally think about CT scans and look for the vascular anatomy beyond looking for maybe where epigastrics are if you're thinking about how to define an inguinal hernia. But I do spend some time and think about where periumbilical perforators may be located if I'm going to do an onlay repair. You can actually devascularize the abdominal wall if you're not paying attention to where the blood supply is coming, like this patient who's got a transverse scar, a paramedian scar, and then had an external oblique release done. Secondarily, if people have vascular disease that's been repaired, you know they have no more lumbar blood vessels, and so their abdominal wall is living entirely off of those epigastric vessels. We will commonly see people who have things like cirrhosis look behind the right rectus abdominis muscle at that very large recannulated vein that then goes out in the middle of the hernia and then runs behind the left rectus abdominis muscle. So think about the blood supply that's going to be in the way of where you're working. Or this patient who had iliac surgery on the left-hand side and does not own a common iliac anymore, and all of her blood supply from her left leg is coming through the low midline. And if you put a port through that or make an incision through that, not only are you going to have a bloody day, but her left leg is not going to do particularly well either. So think about the vascular anatomy. Lastly, Johan showed us where the nerves run, so I'm not going to go over that, but looking for denervation is a very common thing that I do as well. This patient had a back surgery and came in with a left bulge, and if you compare right and left, humans are generally pretty symmetrical. These are not symmetrical, and there's a denervation on the patient's left-hand side, and that's what he looks like in clinic. You can find denervations very commonly. The left rectus in the patient on the left, actually both of these patients, the left rectus has been denervated from colorectal operations. And then this patient with a peristomal hernia who came to see me in a wheelchair, and I said, "Why are you in a wheelchair?" He said, "I can't walk." I said, "You have no muscles." So we sent him, and he's actually got spinal muscular atrophy. I should not be making that diagnosis on your peristomal hernia CT scan, but if you look carefully, you'll see those things. Lastly, this is just a good slide to take a picture of for inguinal anatomy. There are really easy ways to use CT scans to diagnose where inguinal hernias are located, in particular to determine whether it's a femoral versus an inguinal. And from Shirin Taufi's work, we know that these hernias are oftentimes present on the scan but are inaccurately reported. So I'll conclude by saying that if you understand the anatomy cross-sectionally, you're going to plan a very good hernia operation. I think this is a skill that you can learn. Practice makes perfect. If you do this every time on your patients, you'll learn a lot about how good you are as a hernia surgeon. Thanks so much.
Thank you very much, Eric. Next is Dr. Eva Barbosa. Delve into our component separation anatomy.
First of all, thank you so much for the opportunity of being here, and I'm glad there's a lot of people at this hour attending to an anatomy session, which I think it's so important. I have no disclosures for this talk, except that you'll not see I'm a very bad artist in terms, I'm not like Johan, so you'll not see any cool drawings on my presentations, but I'll do my best. So, all you ever wanted to know about anatomy, that's so like surgeons. Of course, we want to know all and fast, like 10 minutes presentation. Give me all so I can suck it up. But actually, we have to think the human brain and your surgical brain like a toddler and a baby growing up. And like Pauli said, you have to make those neural connections about the 3D anatomy, and that takes a long time. You not perceive anatomy the same when you're a student, when you're a resident, and when you're a consultant, and when you have years of experience. So build up that kind of anatomy because it's very important. And the main thing that I want to give you of my talk is anatomy is not one direction. It's not flat. It's not, I don't know if I have something to, no, maybe not, to point out. It's not 2D dimension. It's a full 3D dimension. So when you go into the anatomy of your patient, you have to go through the textbook anatomy, the preoperative imaging that Paula just showed us so well, the the physical exam, the intraoperative anatomy, because we get surprised a lot of times. We went through all that, and then the anatomy that we are seeing is now different. And then we have to look into the functional anatomy. Have we changed with our surgery? And Eric just showed us a lot of examples in the way we changed that anatomy. And we don't want to change it to a bad function. We want to have a functional anatomy at the end of our surgery. So component separation, you know, it's been there since the 50s, popularized by Ramirez in the 19th, and it's essentially external oblique muscle release. It's nothing more than that. But saying that, there's a lot that can happen. Do we still need it? Of course. Sometimes we just don't have the posterior layer to do posterior component separation, so we need it. And in some patients, it's the way to go. So we need it, and we'll be doing it for a long time, and give us that extra space to restore the midline, the mobilization that we need. But there is problems with anterior component separation, and there is problems making that release. And anatomy answers to those problems. What are the problems, and what can we do about the problems? So Johan just talked about this a lot. You know, external oblique, it comes from the 5th to the 12th ribs insertion until the ilia crest, inguinal ligament, pubic tubercle, you know all that. What pictures, most of the times, the textbook pictures do not show you is that, for instance, here, you can see that the aponeurotic part of the external oblique, it seems the same almost, but it's not, because in the superior part, it's much more muscular than the inferior part in the medial part, and that gives us changes in the surgical anatomy. You cannot, when you go through external oblique release, you cannot go through the semilunar lines. That will be a huge mistake. But then again, like it has been shown now, semilunar line have changed a lot what we perceive of it. So it's nearly impossible that you do such kind of a mistake in the anterior component separations. You can see bulges there, and more like rectus abdomen bulge and bulging in the semilunar part, but that's not often so frequent. The big problem with anterior component separation is actually the irrigation of the skin, because you have the 3 zones of Huger. And if you cut the umbilical perforators that are really dependent on those epigastric system and a part of the circumflex and superficial epigastric that come from the femoral nerves, and if you cut it that, you can have skin ischemia. So there's a lot of techniques that try to preserve the perforating of the periumbilical. But sometimes you cannot do it because you have to do this huge flex, because the skin is so far apart and the hernias are so big that you have to do some kind of dissection. The nerves are not a problem in the anterior component separation because they go between the internal oblique and the transverse, so that's not really a problem. In the inferior part, and we don't go interior component separations very low often, but in the inferior part, that could be a problem with the L1 nerves. So preoperative physical anatomy, and you see all these patients, and sorry, because patients do not show as in textbooks. They show like this, and you have to do your anatomy around this. Imaging anatomy, Eric Polly just went through that, so beautiful. And you can see there that what I want to show in the that slide is that the external oblique go superficial to the ribs, so there's an important landmark that you need for your anatomy. And sometimes you can use imaging in intraoperatively, if you're having a hard work finding where you're going to cut, you can make just a little cut, or you can use ultrasound to figure it out where is the anatomy in that patient, and I use it a lot. When you have to do the big flaps, just preserve, it takes some patient and to go around the perforators, but you need to preserve the perforators, otherwise you can have big problems. And here you can find the anatomy, intraoperative anatomy that we want to go through, open and minimal invasive. And open, you just dissect the subcutaneous, as you see there, you don't cut the perforators. And minimal invasive, endoscopic, you see the semilunar line, you see the internal oblique on the bottom, and then you just release the external oblique. And as you're releasing the external oblique, you also have to go into subcutaneous, into the scarpas, so you can fully retract and fully give that extra mobilization that you need. As you're going to the upper part, you see here the ribs, and you can see that you have to be more careful with the dissection because as you see here, the external oblique is much more muscular, so you need to have cautery carefully so you don't have any bleedings or hematomas after. One of the things that I do that I like to do when I do anterior component separations is, as you're going to see, to put on onlay mesh and reattach the external oblique. So the functional anatomy, and George Diaz did this beautiful paper that you see here, is that we actually change the abdominal wall. And we don't see it so much when you do transverse abdominal wall release, but we see it with the external oblique release that you change it permanently. It shifts laterally, the external oblique permanently. And one of the things that I like to do, and you see that in that picture, is that I like to put, like Carbonell Bonafé, an onlay mesh and reattach my external oblique on that mesh so I can have a little bit more of a nice function in that abdomen. So to take home messages, to perform abdominal component separation without complications, you must understand the anatomy inside out with a full 3D perspective. Your patient, anatomy, textbook, imaging, everything. To prevent complications, avoid big skin laps, do it minimal invasive, but if you have to do it, preserve some of the perforators. Otherwise, you get so much of skin complications. Pay attention to the extremes and the external oblique, special in the upper, that's very muscular, so you have to cautery well, otherwise you'll have hematomas, and reestablish the anatomy in the best way possible, because function, at the end of the time, it's our goal in our patient. Thank you so much.
Thank you so much, Dr. Barbosa. Next, we have Dr. Miguel Angel Garcia Ureña. He's joining us from Madrid, Spain, and we'll talk about anatomy of the Madrid modification.
Okay, here we are. Thank you so much for the podium to talk about the Madrid modification of the posterior component separation. And I don't have any disclosure related to this specific talk that I'm going to try to focus more in anatomy. So the question is why and how to perform our suggested modification. You know that probably the best goal ever scored by Cristiano Ronaldo is the one against Juventus. And I consider that that was, like this goal, no? And I think Yuri Nowitzki is still my Cristiano Ronaldo of this retromuscular approach. So what is the difference? Here I can draw the lines of the section of the lateral section of the posterior two sheath and the transversus abdominis muscle and the posterior lamellar internal oblique muscle suggested by Yuri Nowicki. And when we started this, we came down to up, and what we do is just interrupt our section on the posterior retusith there, and we just follow the myofascial limit, the authentic linea semilunaris, to avoid cutting the fibers of the transversus abdominis muscle. So when I talk about this and publish it, and Philippe Muchon told me, you have to put a name to this technique, and no, there's a lot of names, there's no need to put a name. But finally it was William Rayport who coined the term Madrid modification, but I don't like this name. I would like to name it Real Madrid modification, as you can see. So my first cadaver dissection was made here, very near here, in Greenville with Alfredo Carbonell. I came to learn the TAR in 2012, and we performed the first one just 1 month later in Madrid. And I have been spent these years dissecting cadavers. So I look like this man for 400 years ago. So what's the reason for this modification is based of anatomy, and is based on the innervation of the rectus muscle and the diaphragm fibers. So when I was editing this video, I realized, I record and I made this procedure, but come on, I'm cutting a nerve there. And come on, I'm cutting another nerve there. So probably because I was making a very lateral cut on the TM muscle, I systematically cut this nerve. So when we started making this dissection, we came to the conclusion that, in the superior part of the abdomen, the nerves arise more medially than we think in the superior part of the dissection. And this anatomy that you can see here in of the arising of the nerves over there is not only an idea of us, you know, it was already published. This is a nice paper published by Yap, a plastic surgeon, talking about the anatomy of the Dieppe flights. And you can see here that he described that the nerves that comes to innervate the rectus muscle arise from 1 to 5 centimeters from the ambibium, exactly the lateral border of the posterior retusith, not the linea semilunaris. And they can pass down behind the transversus muscle and arise more medially than we think. So this is what we have also made in the study, what we have already finished, that we have tracked the nerves, and in fact they are there, and you can track the nerves to lateral to check that these nerves that comes more medially are the nerves innervating the rectus abdominis muscle. And what we have done is that we have done some measurements in 30 consecutive cadavers. So we have made this distance from the xiphoid parallel to the linea alba, and then the distance from the linea semilunaris, from the myofascial limit of the TM muscle. And what we have found is based in this drawing, when you can see the dots over there, and you can see that more than 50% of the nerves come more medially to the myofascial limit of the transversus abdominis muscle in the superior part of the dissection. And now that, to be sure, if I can have the audio, please, I will show you that we can even, to be sure that these nerves are innervating the rectus abdominis muscle, we have monitored 10 patients, very similar to what you can do to monitor your laryngeal nerve in the thyroid surgery. And you can see here that you can change, of course, the electrodes to see the different part of the rectus muscle innervation. You can see that in the inferior part of the abdomen, the nerves arise really very lateral, but more cranially. As you can see here, only 1 centimeter from the linea alba, there's a nerve innervating the rectus muscle. So this is one of the reasons we made this modification. So, and the other reason is about the diaphragm. Yesterday I presented an oral communication about that we have also made a study on cadaver torsos about this anatomy that I didn't understand until I watch this video from the robot, courtesy from David Lurie that he presented in the European Hernia Society Congress in Barcelona 2 years ago. When I saw this video, I understood that there was some fibers of the diaphragm constantly inserting on the posterior rectus. And we have also measured these fibers, and they can insert between 2 and 4 centimeters from the xiphoid. So how then we perform based on this anatomy? So what we do is summarized in this cadaver dissection. You can see here that we have made this dissection retrorectus, but not so classical. This is the landmarks, the ambibium, or you can name it the lateral border of the posterior rectus. That's too long, so I agree with Philip Musoms to call it ambibium. And then we have the peritoneal fat distribution, and what we do is make an incomplete ribs. So we stop 6 centimeters below the xiphoid, and then we make our way through the Boros, what we consider the Boros pathway, that is easy to do, and the epigastric pathway. So what we do is the lateral section on the posterior rectus is just to join these 2 spaces. But first, go peritoneal in the Boros space and go peritoneal in the epigastric pathway. Just to show you, if I have time, I'm going to show you that the Boros pathway, you know that the Boros and rectus space are not freely communicated. You have to break some fibers on the intermediate fascia, or has been called also the inner layer of the fascia transversalis, but you have to cut something or tear. You can tear with your fingers and pass over there. In the cranial part of the dissection, you can see here, summarized also in this cadaver, that we stop the incision on the posterior rectus, and then what we are doing is taking the advantage of the peritoneal fat distribution. This is what we call the fatty epigastric rhomboid. It's not only the falciform ligament, because it's also in the left side of the abdomen, and you can peel off the fat from the posterior rectus completely, and you can see the fibers of the TM muscle. You can here become aware of how medial the TM muscle is coming to insert almost in the linea alba in the superior part of the dissection. Now we advocate to go a few centimeters laterally, probably 2 to 3 centimeters laterally. We change plane and step up to pretraversalis. So we are in the plane of Yuri Nowicki already. And you can extend your dissection over there. To see the difference, this is the difference. So we stop, and this would be the classic one. Just keep on cutting the posterior rectus. But the problem of going there is that the posterior rectus, as Johan Renard has explained today, inserts over the xiphoid and over the chondrocostal margin. So it takes you to nowhere. And this is the main difference between both. This would be the TAR, and this would be our modification. So you can, of course, obtain pictures similar, and in our YouTube channel you have several examples of complete videos of this, but probably the most tricky thing is the subxiphoid dissection. So we have already made pretraversalis on both sides under the posterior rectus, and we are focusing now cranially on the subxiphoid, and we have to cut through the fat and leave this fatty ball, or the old fatty triangle, attached to the xiphoid. This is the best way to get there and follow the dome shape of the diaphragm without injuring it. And so this way, we completely preserve the innervation of the rectus muscle, and we can go up to the central tendon of the diaphragm. You can see that we can reach the central tendon without the need to perform a posterior component separation. This can be done even in simple ribs that we will also talk tomorrow about the modification of the ribs based on this modification of the TAR. So finally, I would like just to tell you that our modification is based on anatomy, on rectus muscle innervation, and the diaphragm fibers insertion on the posterior rectus. That the tricky thing is to go peritoneal first at also the group of Todd Henniford taught us to go completely peritoneal in the epigastric area and also in the rectus space, and be always sure that there's no muscle on the floor on your dissection. And that's a quite tricky thing to do to avoid any injury to the to the amphibian or the simular line. And the appropriate learning, of course, based on workshops, observerships, of course, mentorship is not an easy surgery. And finally, I would like to thank all my masters in abdominal wall, starting with Alfredo Carbonell, Jennifer Conrad, Yuri, David Lurie in the last 4 years. And of course, this is not my idea. I'm very proud to work with a very good group of people that push a lot, and everybody has made something to suggest to this modification. So I would like to thank my Real Madrid team. Thank you so much.
Thank you. Those are some beautiful videos. Now the one and only Dr. Edward Felix is going to discuss the essential anatomy of posterior repairs.
Thank you. I have no disclosures to give, and we're going to hopefully give let's see if I can figure this out, a very practical lecture. Because I knew I'd have a little bit too much to drink on my birthday last night, I've enlisted a few of my friends to help me demonstrate the principles that I wanted to show you today. First of all, I have Sleepy Joe and his donkey, Roxanne Liu, Sharon Tofig, David Laurier, and David Chen are all going to help me explain what I want to show you, which is that knowledge of anatomy is important, but you have to know how to apply that knowledge in surgery. That's the difference between a surgeon and an anatomist. We have to know how to apply that knowledge of anatomy. You just have to look at the clock. So you have to know your anatomy, but you have to know what to do with that anatomy. It's knowing the anatomy and what to do with it. Let's talk about femoral hernias first. So we're going to be very practical. Understand the location and the appearance of the iliac vein. So that's your anatomy part. Understand how a femoral hernia alters that anatomy. What makes it abnormal in that patient? An incarcerated femoral hernia obscures the normal appearance of the iliacs. Can you make that a little louder? Is that we can dissect the femoral hernia in every patient. And many studies have shown that 10% of recurrences are missed femoral hernias. So here's Conrad dissecting out a femoral robotically. I would, of course, do it laparoscopically, but what the heck. What's important is this. If you see fat crossing the vein and going towards the femoral area, that tips you off that there is a femoral hernia. You must look for that in every patient. So you see the femoral hernia and you see that vein. You must see that vein. If you don't see the vein, that means there's a hernia crossing it. How about the nerves? How does anatomy apply? Understand the location of the nerves. Understand how to protect the nerves from injury and irritation from the mesh, something we didn't do in the far past when I started doing this, which is obviously done now by better surgeons than myself. In approximately 90% of patients, the nerves are below the iliopubic tract. And we all know why we don't put fixation below the iliopubic tract. But 10% are above the iliopubic tract. And so you must be very careful if you're going to use fixation, where to place that fixation. Understand the proper plane of dissection. If one is in the proper plane, the microfascia will protect the nerves from harm.
Here's the five incisions that are being made, and I'm gonna highlight the visceral side of the artery space, which means I'm gonna say it's the perineum. I'm not gonna say it's the abdominal wall. And I said all the fibroblastic tissue and small blood vessels off of the perineum. Good. attention provided by the left hand or the non-dominant hand really helps. So I'm going to dissect all the fatty tissue and small vessels off of the peritoneum to get into the right plane. And when you're done, you'll have a nice layer of microfascia over the nerves to protect them. Thank you very much.
Yeah, this is something we didn't do in the old days. And I think this is a very important change that the more modern surgeons have shown is to protect those nerves, and you will decrease postoperative pain. Why transect the round ligament in females? So female surgery is somewhat different. We don't want you transecting the vas in us males, we hope, unless you're doing a vasectomy. But you can transect the round ligament in females. But you have to know of the anatomy. Transection of the round ligament does not make the uterus unstable. So it is very safe, and I think it's important. Transection is safe if done only correctly. Understand the relationship between the round ligament and the genitofemoral nerve. To preserve the genitofemoral nerve, knowledge of anatomy, again, is essential, because if you don't know the anatomy, you're going to cut that nerve. Sacrificing the nerve will lead to a very, very unhappy female patient.
Let's review the safe handling of the round ligament. First, it's very important to understand your anatomy, specifically the location of the iliopubic tract in relationship to the round ligament. It is safe to hold the round ligament. Retract the ligament as far away from the retroperitoneal contents as possible, as well as away from the internal ring. Note the location of the genitofemoral nerve. This runs along the psoas muscle deep to the round ligament. Skeletonization and then transection of the round ligament is recommended. There is a consensus among specialists that transection of the round ligament has no negative physiologic consequence. Meanwhile, transection of the round ligament may afford improved hernia repair with lower risk of chronic pain. The branches of the genitofemoral nerve are often difficult to identify unless the patient is quite thin, and it's generally not advisable to do so. In this patient, the femoral branch is easily visible. It's not until you dissect further medially that the genital branch is barely visible.
So a couple important points. The genitofemoral nerve accompanies the round ligament at the ring. Therefore, transect the round ligament significantly proximal or cephalad towards the head. Always, always cauterize or endoloop the ligament, because there is a vessel in that ligament. And if you don't, you will be back in the OR for postoperative bleeding. So you must know the anatomy. How about lipomas? And this is controversial for some people, but not for me. A lipoma in the indirect space is a hernia of an extraperitoneal structure. As my Professor Nehus taught us, it's just like the bladder. If a lipoma is in that space, it's a hernia, and don't call it anything else. Lipomas of the groin can be symptomatic or asymptomatic. A missed or retained lipoma is a recurrent hernia. Lipomas of the cord are adjacent but separated from the vas and vessels by microfascia, a la Laurier. Lipomas have their own retroperitoneal blood supply, which means you can preserve them and use my trick of putting it on top of the mesh to keep your mesh down. They cross and cover the iliopubic tract, an important landmark. They pass through the transversalis sling.
You can see that by staying in the visceral plane laterally, we have preserved that protective microfascial layer. Here we are bluntly opening that layer and looking into the internal ring, and there we see the yellow lipoma. With a gentle touch, we try to preserve microfascial coverings, and we separate the lipoma from the spermatic cord, which has its own distinct intact microfascial coverings. Here we see the transversalis sling wrapping around the core. Here you can see that the lipoma actually herniates through this transversalis sling, and here is its own microfascial covering so that the lipoma is in a separate microcompartment from the spermatic vessels themselves.
Thank you, David. And here is the lipoma, and what you're going to see, which is important for me, is that iliopubic tract is the landmark you must always see when you're doing your hernia repair to get the critical view. Sometimes more is not better. All of us surgeons know that. Sometimes more is not better. Should we close or suture close hernia defects, the direct defect?
I've enlisted someone to show you why you shouldn't do something. Here you go, David.
Thanks so much, Ed. I'm happy to talk about this. So this is not a new topic. When IHE first started, Yusuf Kudzi posted this direct defect, any benefits, and showed great robotic videos of closure. And so when we have big M2, M3 defects and L through L2, L3 defects, sometimes it's tempting to say we can close that. However, this was the answer, and Ed Felix made it very clear. He just said, no, stop it. And Guy Veller said never did it for recurrence reasons. It tried to decrease seromas, but then it wasn't necessary, and you take some risk. And what is that risk? So when you sew from the bottom, this is the area that you're sewing in. So that area of Haselbeck's triangle or of the internal ring, you're closing that area. But on the other side are the iliohypogastric nerve, the ilioinguinal nerve, and the genital nerve that runs within the cord. And remember, the cord would be smack dab in the middle of that. This is a video that will show that. So here is opening the canal for one of these big hernias here. I'm opening up the transversalis fascia. And when you do that, here you can see, this is like Liechtenstein anatomy from the back. Here's your cord structures. That's cremasteric fibers wrapping around it. That's the vas deferens coming right down there. And now you can see there's the ilioinguinal nerve right on the top up here coming across the field. And so that, if you don't know where it is, and especially with that transversalis fascia in place, you can miss that. Now on this medial side, you can see here's the arch here of the ligament of Henle, and there you can see the iliohypogastric nerve there, same as in the meeting of the conjoined tendon there. But that's what happens is if you just sew from the backside and you don't open the floor, you can hit ilioinguinal, iliohypogastric, or the genital on the other side. But really, this is the main thing. If Ed Felix tells you not to do it, it's not part of the 10 Commandments. Really, there's no reason to do it.
So only through knowledge of anatomy and proper application of that knowledge can one achieve what both Jorge and I feel is the critical view of the MPO. The steps I believe are important in reducing failures and misadventures. Understanding proper inguinal anatomy is not enough. Even though Johan showed you that anatomy, you have to know what to do with it. One must know how to apply that knowledge. It will keep you and your patient out of trouble. It will decrease recurrence. It will decrease immediate and chronic postoperative pain. I thank you very much.
Okay, last and certainly not least, Dr. Andreas Koch to discuss some tissue repairs for hernias.
Morning, everybody. Thanks for the invitation to talk here about tissue repairs, especially after this phenomenal talk of Ed Felix after his birthday. And thanks for having me here to talk about the anterior anatomy. And I have nothing to disclose. And what happens when we don't follow the rules of anatomy. We have learned last year in the Super Bowl, when you don't read the anatomy of the game right, then it will end up in a disaster. So let me go the step to the functional anatomy, especially under the view for the so-called sports hernia repairs. We have to know the functional anatomy, like Eva said, for the abdominal wall. It's the same in the groin, and we have to know how many muscles are around the symphysis to understand the symphysis as a joint, and all the problems we can achieve out of that with the high load and high performance athletes. And when we see when we see how the adductor longus and the rectus abdominis are working together, then we see there's a problem in the so-called pubic fascia between the adductor longus insertion and the rectus abdominis. insertion, and that leads to a weakness in the posterior wall. And following this weakness, we get compression to the nerves, and then we can localize the problem when there's a lot of load on the inguinal floor, and we can map these nerves and we can stabilize the floor. But stabilizing the weakness alone is not enough. Sometimes you have to do a lot more on the adductor release and the release of the rectus abdominis. Open inguinal anatomy. First, I will step into the Disada repair. It's a very interesting repair because there were some good randomized trials between Disada and Liechtenstein repair, and they had the same results. What means Disada? Disada takes a flap from the external aponeurosis and covers the posterior wall of the inguinal floor with this flap of out of the external aponeurosis, and then he create a new flap of the external aponeurosis to close anteriorly the external oblique again. But the problem, it's like Ed Felix said, he's not searching for a femoral hernia, and we have to look out for a femoral hernia. That is how it looks like when you did a so-called Disada repair. And the shoulder dissection alone, that allows us any repair following with prosthesis, without a mesh, and we can reconstruct the posterior wall anyway, and we can decide intraoperatively how many reinforcement do we need. And now I will show some drawings I got from Robert Ben David directly from the Shoulders Hospital. These are very historic drawings, and then I come to some videos. But these drawings are showing the anatomy of the inguinal floor. And at first you have to open up the external aponeurosis. Then we are getting into the inguinal floor, seeing the nerve structures, the ilioinguinal nerve and the cremaster muscle. After that, and that's a very important point, to mobilize the inguinal ligament from the iliac artery up to the pubic to the iliac crest, to mobilize the inguinal ligament. And then that's the main step of the shoulders repairs: open up the posterior wall, splitting the transversalis fascia to see the preperitoneal fat, and then you can explore the floor to see if there is a femoral hernia or not. If there is a femoral hernia, you can move to a preperitoneal mesh repair, and you can cover the femoral defect as well. So, and then the reconstruction, you start on the pubic bone with the first suture row, taking the lateral border of the posterior rectus sheet to reconstruct with 4 suture rows, 3 layers, these posterior wall anatomically. And you see from medial to lateral, and then going back from lateral to medial, the original shoulder cuts the cremasteric muscle. I personally split the cremasteric muscle and cover or reconstruct the internal ring, not with the stump of the cremaster. I take a part of the internal oblique muscle to reconstruct the internal ring. And then you're going back from lateral to medial, and then again taking the conjoint tendon from medial to lateral and back. And now it's published in the textbook of hernia together with Robert Ben David. So I start with this kind of water dissection. I take some local anesthetics. Then you can enter the floor by opening the external aponeurosis, mobilizing the inguinal ligament, and then you have to see the preperitoneal fat. When you don't see the preperitoneal fat after opening or splitting the transversalis fascia, you have never seen a shoulder dissection or a shoulder repair. And then you see this lateral border of the posterior rectus sheet. It's the so-called white line. And that's the first suture row for the reconstruction. And we have published the standards in hernia, how you have to do these 4 suture lines. And I will show you some short videos. And here you can see a wet gauze is in the preperitoneal space to do the preparation of the preperitoneal space and then take the lateral border of the rectus muscle, posterior rectus sheet, and then go up from medial to lateral. And there's one trick, what I'm doing with the indirect sac. The indirect hernia sac, I medialize the sac behind the epigastric vessels, and I include the peritoneum of the hernia sac into the first suture row. So then we have, on one hand, we have fixed the indirect sac, and we have kind of peritonealization of the posterior wall. And then step by step, all these sutures to fixate the internal oblique and the conjoint tendon to the inguinal ligament. And finally, the closure of the external aponeurosis with a running suture. And you can do a preperitoneal reinforcement. For instance, I call it reinforced shoulders using a long-term resorbable mesh like a Phasix mesh to place it in the preperitoneal space and do the anatomic reconstruction on top of that. This video is not running. So you see here the preperitoneal pad, and you can do the preparation of the preperitoneal space. There is the white line, the lateral border, and then you can place mesh, long-term resorbable, or in type 3 direct hernias, I very often use permanent meshes as well for preperitoneal reinforcement, and then do the reconstruction of the inguinal floor on top. So you have the combination between reinforcement and reconstruction. You can use permanent meshes in that space as well. So tailoring in young patients, I think with a shoulders dissection of the inguinal floor, you can do everything. You can tailor intraoperatively with the classification and the individual risk factors of the patient. And then you can do a non-mesh repair, preperitoneal mesh repair combined with anatomical reconstruction of the floor. Then we are talking about the reinforced shoulders. Let me conclude. The shoulders preparation of the floor is the way to a real tailored approach between no mesh, absorbable mesh, or permanent mesh. And we have an anatomical reconstruction of the floor with or without additional reinforcement. And finally, whatever we do, we should do it properly, and we will have good results. And the anatomy finally is the key for success. But we have to discuss, especially in young patients, how many foreign material do we need in the primary surgery. Thanks to my mentor, Robert Ben David, and thanks for your attention.
Okay, we have just a few minutes for questions. So if anyone from the audience has one, we'll start there. Over here to the left.
Good morning, Lucian Panay from Minnesota. My question is for Andreas. Andreas, when you do reinforced shoulders, typically when we do a posterior repair, we parietalise the cord. So we put the mesh kind of over the cord, almost like in a sugar baker, if you will, right? When you do a reinforced shoulders from an anterior approach, how far you go laterally with the mesh underneath the cord?
Laterally, I go up to the iliac crest.
Oh, you
So,
do? So
yeah,
the mesh is
yeah,
pushed behind in the preperitoneal space. So you do a preperitoneal dissection.
you're
Right.
exactly in the same plane like in a TAPP.
Yeah, thank you.
Dr. Cook.
Thanks. Kent Kirscher from Charlotte. Question for Andreas. My personal bias and belief is that sutures cause pain. More sutures, more pain. And in ventral hernia, inguinal hernia, I think a lot of us believe that putting in fewer sutures is a good thing. When I see your beautiful video, and I know that you have the ability to do this operation well and safely, it occurs to me that the shoulder ice requires a lot of sutures. So what is your experience in terms of acute postoperative pain and also long-term neuropathic pain in patients that have a shoulder ice? And how do you handle the nerves? Ed showed us a nice video from behind. There's a lot of nerves there. You clearly see them from the front side, but how do we mitigate that risk?
Yeah, so intraoperatively, I take care of the nerves, explore where the nerves are running, and sometimes if necessary, I put a sling on the genital branch to take care of the genital branch to see where it's running, that you don't take the genital branch into the suture row. For the sutures, I use in the first 2 suture rows, I use polypropylene. And when you do the first suture row, when you take down the lateral border of the posterior rectus sheet, the rectus muscle down, all the other structures are falling to the inguinal ligament. So you do just imbricating sutures with PDS to fix it for the first period. So with that, I've minimalized the suture material I have. And finally, it's there's not too much strengthness on. And at the end of the operation, I infiltrate some local anesthetics, long-lasting local anesthetics, and the patients are walking around 3 hours after the surgery.
Thank you. I also have a question for Dr. Andres about the shoulder ice. Thank you for the presentation. It's a great picture. I think for once I understand how to do it maybe. And I do appreciate the preperitoneal dissection, that almost like an MIS repair. Question for you, is there any specific precaution or thinking for female shoulder ice? Is there anything for how do you handle the round ligament?
And especially in females, it's mandatory preoperatively and intraoperatively to search for a femoral hernia. Because when we see all the studies from the Scandinavian countries, they are in the small letters, they are asking, oh, these early recurrences are overlooked. Femoral hernias. So you have to search for a femoral hernia, and when I find a femoral hernia, then I place a preperitoneal mesh and I change it to a preperitoneal mesh repair. Yeah, and the most, so 2/3, 65% of female hernias are indirect hernias. Yeah, 50% are femoral hernias, but 65% are indirect hernias. And in young females, in my personal opinion, a Marcy repair, it's good enough. Yeah, cut the indirect sac, narrow the internal ring, that's it. Yeah, but you have to split a bit in the transversalis fascia to explore for the femoral.
If I can add something to that, when Ben David published his original incidence of recurrent hernias from the shoulder ice, I was fascinated because he showed the exact same thing we did, is that 10% of his recurrent hernias that he repaired at the shoulder ice, even in males, were misfemoral hernias. And that's why whether you do a shoulder ice or whether you do a Lichtenstein, you must, in every male patient, look for that femoral hernia. If you don't, you're going to get a 10% recurrence rate, which is unacceptable.
Ed, would you explore somebody who has imaging that doesn't show anything in the femoral space?
Say that again.
If a male patient shows up with a CT scan that shows no femoral hernia, would you still explore?
Well, my experience with CT scans is limited since I'm in the era before ultrasounds. But so what I would say to you what I would say to you is, yes, I think that I'm not going to accept that. But if you tell me you've done a study showing that in comparing CTs versus what you find clinically, I would have to go along with that.
Thank you.
All right, very good. One more question in the middle.
My question is for Dr. Arena for the Madrid modification. Thank you for that explanation. My question is, have you found when doing this, because you're not releasing the posterior sheath and the muscular portion of the TA, does that limit your medialization when preserving that in either anecdotally or in your cadavers?
Yes, that we haven't studied on that on cadaver, but I think that even the results of the cadaver are not, it's difficult to apply any cadaver dissection to the real life. But it's true that we don't cut the last 6 centimeters of the TA muscle, that we cannot obtain such a big medialization. But the rest of the procedure is just the same as the lateral release of the posterior to sheath and before the Botox era, before 2018, we had to bridge 40% of patients. That's a lot for all. Small bridges, but maybe 2-3 centimeters, most of them. But now with the Botox, we only bridge maybe less than 10%. So yes, but we can obtain also a very good mobilization with this technique. But that's a good point. No? But theoretically, we will have to demonstrate. But I don't have the data.
Thank you.
All right, fantastic. Thank you to all the speakers. This was a fantastic session. And just a couple of quick announcements before everyone takes their break. Special thanks to our silver sponsors, BD, Intuitive, Medtronic, and Pacira. Please do take a few minutes to visit them in the exhibit hall, as well as our other sponsors. We could not do this meeting without them. Our next session here will be the fireside chat coming up in 30 minutes. Another few highlights of the day. Come cheer on the hernia Olympics this afternoon during the break. And a reminder to claim your CME online. That has to be done by October 21st. Hope everyone has a great break. See you for the next session.
There will be no real fire, by the way. I asked.
Liars.